question. Thank you, Alexandra.
Thank you. So every good system has redundancy built in. And then the Hungarian Pancreatic study group has a second Péter Hegyi, just in case the first one is unavailable.
Thank you.
So Péter Hegyi will present about nothing less but, again, early chronic pancreatitis, the topic of the day. Peter, floor is yours.
Thank you very much. Good afternoon, dear colleagues, ladies and gentlemen. What I would like to present today is a hot topic about the definition of early chronic pancreatitis. And I would like to talk about our multi-center international study with the animal model in this project. I would like to begin by drawing your attention to problem of chronic pancreatitis. As we all know, chronic pancreatitis is a degenerative inflammatory process which leads to the progressive deterioration of the exocrine and endocrine function. Function, and it has a negative effects on the quality of life and increase the risk of the pancreatic cancer. The early chronic or the early diagnosis for chronic pancreatitis is very difficult, problematic, and there are only few clinical studies in this topic, and therapeutic options are scarce. And now let's move to the topic with the early chronic pancreatitis. The research of early chronic pancreatitis is challenging. As I mentioned, it is a hot topic, and there is an international effort to better understand it. The most recent international consensus conclude that we need to make progress towards the definition and diagnostic criteria for early chronic pancreatitis. Our aim was to identify these biomarkers, which can be correlated and detected early formation of chronic pancreatitis. And now let's move to the topic of these biomarkers. But where should we look for these biomarkers? This is a very big question, and it is clear based on the diagram by David Whitcomb and et al. That we can identify these biomarkers among patients these patients suffering with acute recurrent pancreatitis. And this is a reason why, for this purpose, data from the chronic pancreatitis registry is not to be adequate. And now I would like to present the topic of methods and the data collection. The Hungarian Pancreatic Study Group started the acute pancreatitis registry in 2012, and after that, the data of more than 1,400 patients were uploaded from more than 20 countries and 26 hospitals until 2017. We divided our patient group or cohort to the three groups. The first group was the acute pancreatitis group, the second group was the recurrent acute pancreatitis RAP, and the third group was the chronic pancreatitis. After that, we could analyze 102 biomarkers, and first of all, we compared which biomarkers had a significant difference between the AP and the CP group. After that, we found 15 biomarkers, which biomarkers showing the significance differences between the AP and the CP group. And now I would like to return to the question of our aim. Our first question was, after which acute episode does the significant difference disappear in these biomarkers? This was the first question. The second question was, what is the average number of acute episodes in chronic pancreatitis where the morphological changes are already present. And the third most important question was, these biomarkers can be detected chronic pancreatitis sooner before the morphological changes. And I am going to present these biomarkers with the following slides. We divided these biomarkers to the three groups. The first group was the pancreas-dependent parameters. The second group was the etiology-dependent parameters. And after that, the laboratory-dependent parameters. And on this slide, we can see the pancreas-dependent parameters, which is the first biomarkers, and this is the pseudocyst. This figure is a very good example of changes in biomarkers along with the progression of AP towards the CP, and patients with the chronic pancreatitis are more likely to develop the pseudocyst than those with acute pancreatitis. And the significant difference disappears after the second episode of acute pancreatitis. That means when we see the other visualization on this graph, we can see more than 20% has the pseudocyst compared with the acute pancreatitis group. On the following slides, we can see the biomarkers such as the amylase level. In case with amylase level, the significant difference disappears after the second recurrent acute pancreatitis. After that, the lipase level, the significant difference disappears the same like in the amylase level after the second recurrent acute pancreatitis. And now let's see the epidemiology-based parameters like sex males. In case of sex, the significant differences between the AB and the CP disappear after the second acute pancreatitis. In the case of age, we can see the same tendency and the significant difference disappear after the second recurrent acute pancreatitis. In the case of BMI, the borderline is after the third recurrent acute pancreatitis. Alcohol consumption, in the case of alcohol consumption, the borderline is after the second recurrent acute pancreatitis. And smoking is very interesting because in group with the CP, we have more than 60% patients with smoking compared with the AP group, where is around 25% of patients. And now the etiology-based parameters like biliary etiology, where the significant difference disappear after the second rub. And after that, the second is a bilirubin level, where is the borderline after the second rub. And after that, AST level, such as the liver enzyme level and GGT level, ALT level, alcohol etiology. Alcohol etiology, when we see this picture, we can see more than 50% in this chronic pancreatitis group has alcohol etiology. And the laboratory-based parameters, we have one. This is a red blood count cell level. Now, at last, we have arrived at conclusion. The answer for the first question is, after which acute episode does the significant difference disappear? The answer is, in these 50 biomarkers, it is after the third recurrent acute pancreatitis. And the answer for the second question is, the average number of episodes in acute pancreatitis with the morphological changes is between 4 and 5 attacks. And the third most important question, these biomarkers can be identified sooner the morphological changes. The answer is yes, because 3 or more recurrent acute pancreatitis without the morphological changes can be considered as early chronic pancreatitis. And this is the most important slide, this presentation, I think that, because in the recurrent acute pancreatitis, after the third attack in this group, where 16% of patients already have established the chronic pancreatitis, but why after this, 15% of patients has acute pancreatitis. This is a probability, the vertical axis of chronic pancreatitis. And these data demonstrate that 3 or more episodes of acute pancreatitis are to be considered as a significant risk factor for the development of chronic pancreatitis. And this is our animal model when we can see the serum amylase level when after the second recurrent acute pancreatitis, the serum amylase level is decreased and induce the CP-like morphological changes. And from this project, an article grew up, and here she is in all her glory. And thank you very much. If you want to go fast, go alone, and if you want to go far, go together. And thank you very much for Peter and for the whole group for supper.
Thank you. Questions, please.
So congratulations on this work. So one of the interesting things about clinical medicine is that our definitions are clinical consensus definitions rather than scientific definitions, but they're to be guided by the best science available. So I think that what you presented is a very clear human picture about how the pancreas deteriorates with continued beatings. We've done some other studies in our laboratory that show that the destruction of the pancreas happens much more rapid if you have alcohol. So I don't know if we can take exactly the number of episodes alone, but I think that what is required is for there to be a clinical consensus of what chronic pancreatitis is before we can make some clear recommendations. This kind of data is terrific evidence to guide those discussions, but it is a consensus definition, just like acute pancreatitis. The definition is amylase 3 times, the amylase or lactase 3 times the upper limit of normal, and the characteristic pain and/or imaging evidence. Well, it's a clinical diagnosis that sort of agreed on. We probably have to do the same thing for early chronic pancreatitis. But I think this data is very helpful in helping to guide the thinking for a future consensus. I tried for 3 years to get consensus prior to this and whether or not EUS could do it, and all I got was bloody.
Thank you very much. And it is very helpful results for the patients when we show these results for the patients after the first and the second acute pancreatitis. It is clearly shows it is a very high risk to develop the morphological changes. That means develop the chronic pancreatitis.
There's a probability.
Probability, yes. And for the patient, it is a very good information. I think that very useful.
So I think for me, the really fascinating issues in the study was that for chronic pancreatitis, we want to see morphological changes, but this very clearly showed that the biochemical or biomarker or whatever we call them, they are much more shows the damage, the continuous damage of the pancreas, then it reaches the chronic pancreatitis. So, and in my opinion, of course, we are far away from perfect consensus or conclusion what is early chronic pancreatitis. But I think we must start somewhere. And of course, there is a US-based also guideline what is early chronic pancreatitis. But if you look at generally in many places, you know, it's not all patients after acute pancreatitis can reach endoscopic ultrasonography. So we must find something which can easily handleable. And of course, there could be other ways around, but at least for sure that after the the third acute pancreatitis, if there is no morphological change, this is already measurable, the parameter. So what we believe from the Gulyás Plus study, because this was a crossover study and the other is a longitudinal one, to have maybe a system like an artificial intelligence system or whatsoever from the huge data, which can predict the real probability of the patients to get chronic pancreatitis.
The other two issues that come to mind that we need to address. The first one is that what is minimal change chronic pancreatitis? And secondly, in younger patients in Hungary and others, recurrent acute pancreatitis is definitely the majority of patients. At Mayo Clinic, it's only half of the patients. So what is the other half? And so we have to weigh these things out as well. So
yeah, but this is what I say, that
yes.
We definitely will not something which, like in acute pancreatitis, you can make it clear. Maybe you have some for this half, you will have some for the other half, but definitely not like in acute pancreatitis, I think. And also, I think for those patients who have recurrent attack, we should rethink the diagnostic criteria of acute pancreatitis, because definitely they are not always reaching about 3 times elevation of amylase and lipase, because they have much less already synthesized in the pancreas.
And the other issue, which was not addressed here, is that part of what you're trying to do is to both diagnose early chronic pancreatitis and exclude the differential diagnosis that has features similar to chronic pancreatitis, but is something different. So trying to understand fibrosis without chronic pancreatitis, which has been recognized, or even diabetes, those types of things have to be sorted out as well. What is true early chronic pancreatitis? What is the differential diagnosis? And what is the probability of it progressing to an end stage?
Very interesting data. But I think there are many, many pitfalls with regards to interpreting the data. I think the only way to get a good, clear picture is to follow patients all the way up to what we already call established chronic pancreatitis, and then look back with your data and your biobank. I think that's the only way to go forward, because everything else is shady. Elastase test is the least specific, and whatever test doesn't help you at all. Of course, glucose metabolism, yes, but you have to discern different types of diabetes, and EOS is worthless. Of course, you can exclude chronic pancreatitis, I guess, and you can show chronic pancreatitis if you have a huge shadow in the stone, but everything in between is nonsense. There's no agreement between observers whatsoever. And I would urge you to work hypothesis-driven, not to take one of the 40 biomarkers and just start analyzing, because you do so many statistical tests that you will find associations anyhow. You have to correct for multiple testing. So I would go very much for hypothesis-driven research instead of doing everything.
Yeah, but how you comment the artificial intelligence one? Because this is totally not hypothesis-driven.
No, but there you correct for multiple testing. The whole system is based on that paradigm.
I'll just comment on this just very quick. I know we're way over time. Even with the machine learning, with the artificial intelligence, you need to have some
hypothesis based on prior data or evidence-based. So you start with lasso, and then from there, you put all your data through the algorithm and see if it finds something that the other evidence has missed before. So there is utility for both.
I don't want you to sleep before the pediatric session.
Okay, Mike.
Stay awake.
Thank you.
Thank you.